Welcome to Public Health Matters, where we talk about matters in public health. My name is Jane Goodman, and I'm a communications specialist with the Nashua Division of Public Health and Community Services. And I'm joined today by our division director, Bobbie Bagley. Welcome, Bobbie.
Hello, Jane. It's good to be here.
It's good to see you. I will make note that we are wearing our masks on air today. We are in the middle of a surge. Rates of COVID-19 are very high in Nashua, so we hope you can all hear us well. But for our own safety, we are indoors. We are still 6 feet apart, but we're just really walking the walk right now.
Yes.
You're here today really to start with a COVID update. We have a surge, as I said. It's not just in New Hampshire, it's everywhere. So let's start with the numbers, and then we can talk about some of the things that we're trying to do proactively to eliminate this virus.
Well, thank you, Jane, and thank you for this opportunity to inform our community on our COVID case update and the latest of what's happening. There is substantial spread of COVID, the coronavirus, around the world, as we've seen here in our own state and here locally in Nashua. If we look at our global numbers, our cases right now have reached 68.8 million around the world, and our deaths have reached 1.5 million. In the United States, we're up to 15.3 million cases, and we're seeing 289,000 deaths. And if you listen to the updates on the news or on CNN, we're hearing things that, these are record-breaking numbers that we're seeing and that we're hearing across the globe and in the United States. If we think about it right here in New Hampshire, we've got some metrics that we've been looking at. We've announced that there's been over 101 cases as of December 10th. So as of...
that's a little, the way they've reported is, so now because there's so much testing, we're getting dribs and drabs. So on December 10th, there were more than 101 cases, but that was left over from the day before.
Correct,
So when we say that
the data's always dragging.
Yeah.
And that's what's expected, because the cases, if you think about it with the testing, we're all testing different days, different times, and as the labs, thank God for the public health lab and those workers, as they get the information in, they push it out. And so the numbers that lag are added in, right? So on average, there's about 672 cases per day over the most recent seven-day period from December 4th until the 10th. And what we're seeing is an 8% increase compared to the previous 7-day period. So again, that substantial spread just continues. So our state turned red probably, 2-3 weeks ago. And as the positive percentage continues to go up, you just continue to see more and more cases, which has us all really looking at, what we need to do, what we need to really ask, our communities to be vigilant around, right? If we look at the total number here, we've got 28,273 total cases with 6,303 active cases.
That's a lot. That's a lot for our state.
That is a lot. It's a lot to try and manage. With doing disease investigation. It's a lot to try and manage with doing contact tracing and contact monitoring. And so that's why there have been some changes in how we're actually implementing some of those measures as well. We have 852 total hospitalizations for the entire time of our experience with COVID. So we're right now in New Hampshire, I would say we're going into about month 10, March. 9-10 months. The world, we're coming up on a 1-year anniversary pretty much for the world. Our current hospitalization, 248.
Right.
And so that number is increasing as well. We have an 8.9% 7-day positivity rate with 7,494 average daily tests. So we can see anywhere on some days from anywhere from 15 to 2,500 tests per day. That is a lot of testing that's going on. And the reason, we continue to do testing is because we still want people to know their status, right? We know that some of the mitigation measures that follow up with that with the disease investigation are lagging because, as we talked about, this 101, the number is lagging. Getting those results is starting to lag as well. So it makes it harder for us to get information back to people in a timely enough manner. What we're hoping is that when people go to get tested, if they have symptoms, Jane, that they're making sure that they isolate themselves from their families, from their friends, and that they are not going to work waiting for these results if they have symptoms.
Right. We always say that. Like, if you have symptoms and you've come for a test, again, you just wait. Be patient.
Yeah.
Go home. Because right now, it's very likely if you're having these kind of symptoms and they're, the cough and the runny nose and those kind of things and the fever and the chills, it's likely that you really have to just stay home. And we've been saying that all along.
Right.
Stay home
right.
if you're sick, no matter what it is.
Exactly.
So,
yes, exactly. We have 21,386 total recovered, which is good. Our recovery rate used to average around 85%. The last numbers that I looked at earlier this week, we were recovering around 73%. And so that's telling us something.
right. We've got more sick people.
Exactly. We're up, unfortunately, to 584 total deaths in our state. 584 individuals have lost their lives to COVID. Again, things that we need to look at, things that we need to pay attention to, because we need to make sure that we can make some changes to help save lives. That's what we have to really start thinking about now. How do we save lives? When we think about, Jane, our transmission rate, so our new cases per 100,000 over 14 days is changing significantly. So if you look at the map that you have there, that dark navy blue shows where those rates have increased up to the highest. So that little bar on the bottom shows the color scale that goes all the way over to navy blue. And if you look at that little tiny spot down there, that's Nashua.
That's Nashua.
That's Nashua.
And that's why I like this map, so people understand this is real, this is here. And it's very apparent, especially when you see this, with the shades of blue, that we're dark blue right now. Currently. It's time to pay attention.
It is time to pay attention, yes. And then the other map that's there of New Hampshire just shows, again, that substantial rate of transmission.
Right.
It's throughout the entire state. So as a state, we all need to take on that personal responsibility of doing the things that we know can stop the spread of this virus. We all need to do that. And, it's sobering statistics that we have here. And these are measures that we have been working with, on a daily basis, right? And so as we continue to see these numbers go up, this is daunting. It becomes like overwhelming, after time.
Yeah, and just on a personal level, I prepare a lot of the data for these slides and for different things and for different press releases and whatever it is. And when we're doing the show week to week, I sometimes just gasp because I can't believe how much it's gone up.
So quickly.
Yeah.
Right.
And when we were doing this in the summer, we really, 10 cases, maybe a week, or, we were really down to low rates. And now, you really, it just really gives you pause. So these are real significant changes that we're seeing.
And what's interesting about that, Jane, is that we worked so hard, at the onset of, COVID in New Hampshire, in March, and then in April, and in May, we saw the numbers go up, and then we were like, we need to do something to mitigate this. We need to flatten the curve. We put certain measures in place, and we did that. So over the summer, yes, we did see those numbers go down significantly. And then once we started engaging, right, in activities that brought us back together, to be with each other, to enjoy, the wonderful things that, are out in our community, we started to see those numbers go up. So we expected for there to be a spike in the fall. We expected for the numbers to go up, in the winter. I do not believe that we expected the numbers to exponentiate so quickly. So you're talking like a 400% increase in some of these places where we're seeing these numbers. So if we look at our COVID data metrics as that were updated from December 10th, we can see our total cases in Nashua at 2,642 with an active caseload of 499. So when we talk about this active caseload, Jane, this is you and I looking at these numbers with the rest of us, the staff at the division. Folks have been repurposed to now do disease investigation. So not only do we have our public health nurses who've been the weekend warriors doing this, since this onset of this pandemic, now we also have you, our communications specialist. We have our health officer, as well as our epidemiologist, joining the ranks and doing this disease investigation, right? Because we're trying to stay on top of making people aware of the situation, making sure that we can get to folks to educate them about isolation, about quarantine, and about exposure and how to reduce that.
And from my perspective, having really been speaking with a lot of people and educating them about what to do for COVID and when they have these symptoms, and them telling me about their behavior and what they did, and without judgment really, but saying, oh, well, I did go out for this party, or I did go for this small gathering, and oh, I didn't think they would be, or we've kept it to our 5 families. The problem is not knowing where everyone in those 5 families has been and who they've been exposed to. So I think that community spread that we're experiencing, it's very real when you're speaking to people.
Right.
And people really need to understand that at this point, their actions really have consequences. And it's very apparent right now with the people we're speaking to.
Right.
Whether they're going to work and getting it and then going out for their holiday dinner. We really have to be vigilant.
We do. And you don't really understand that until you're on this side of it, right? Until you're making those calls, until you learn, or until you hear, the story of, maybe even a family that says, I don't know how we picked this up because we have not gone anywhere. We haven't done anything. All we do is go to work and home. Well, if there's someone that's asymptomatic that came into work, that's an exposure. So there's so many, and I'm glad that you said, Jane, that there's no judgment. And that's what we really want people to understand. We're not, judging, people or individuals with their exposure. We just want people to understand that there are many ways that exposure can happen. And the best way to reduce that is by us reducing our activities with others outside of our bubble. And we talk about the bubble. That bubble is so important. And maintaining that personal bubble space when we're out in the community, that 6-foot social distancing that we've been talking about, and wearing that mask so that we protect, ourselves from respiratory droplets, and others are protected, from us as well. But those personal bubbles and those family bubbles, truly making those personalized bubbles, are so important. Because when we engage, even in small gatherings now, we're starting to learn that the virus takes advantage. It takes, the opportunity, right, to show its ugly head, to rear its ugly head, and spread. Our new infections per 100,000 in Nashua is at 823.6, Jane. Right? And so the sentinel number was once it got over 100. We're talking 820.
8 times that right now.
Yes, exactly. And our new hospitalizations per 100,000 is up to 2.2. So our new hospitalization rate because of COVID, that number is still manageable. We're hearing from our hospitals how we're starting to impact them and how it's starting to impact their workforce, but it's still manageable. But how long is that going to last? If we all keep doing what we're doing, and I say we all because I'm a part of, New Hampshire, I'm a part of the communities here. I work here in Nashua. If we all continue doing what we're doing right now and we don't make some other take other actions or other steps to make sure that we're maintaining that social distancing and wearing our masks and continue to be vigilant, because this can make you weary and you can grow tired of this. If we don't continue to do those things the way that we need to, we are going to impact our hospitals, and we are going to see that percentage go up. Hillsborough County right now, cases to date 12,082, and active cases 2,315. Our level of community transmission still remains substantial. And this, Jane, is what we're working on, trying to get our community to partner with us so that we can slow that down and stop the spread. That's, it's been our mantra, stop the spread. We've been talking about this for months. And now it's even more of an imperative that we do this because we're now starting to see the impact on our families, in our hospitals. So this slide that we have here, Jane, on the case counts by week in Nashua, again, is very telling. And I like this because this is a visual.
Yeah, exactly. You can see that going right up.
You can see it.
There's no question that the far right, we're not doing so well. And the other thing, Bobbie, just to point out, is that Nashua is faring worse than the rest of the state right now. So when we looked at the 8.9% and we're at 11.2% positivity, you realize, we are a more dense population.
We are.
We're closer together. It's more urban. So, Nashua, and I would add Manchester, we are bearing a lot of the brunt of this right now. And, but you can see here that Nashua is, climbing daily, or
daily.
weekly, I should say.
Yeah,
But
yeah. Our average number of new cases per day by week, both Nashua and the state of New Hampshire have seen increases in the average number of new cases per day, per week since the beginning of September. And again, the expectation in the fall was that these numbers would go up. Like I said, I don't believe that we expected for it to exponentiate this quickly. And so we really have to take that into consideration. So again, I love this slide because it's a great visual. When we first got started back in March, you can see what it looked like. And now you see where we are in December, up to almost 400 cases, per week. And now we get to percent positivity.
which we wanted to take a little bit of time on because this often you hear, oh, we're testing more. That's why we have more positive cases, which nothing makes me tear my hair out more because it's just, we have to understand that percent positivity is simply a rate. It's math. So we try to show that today with an equation so that it's very clear. We have another graph that I think you would like because it does show the increase. It's very clear.
Right.
But we also have an equation kind of telling people that 49 positives a day over 456 tests. And when you're yielding 11.1% positive,
That's high.
way above where we want to be be safe.
And the thing about this, Jane, is that this is of those who have tested, right? And so for those that, haven't tested, we know that there's some undercounting of what is really out there because those folks haven't been tested. But just going by this number, as you said, this 11.1% positivity rate, that's high. It's like over one person, one out of every 10.
Right.
So that's pretty high. That's
when
how
we're
we get to that substantial.
Yeah, when we're seeing those cars come through in our testing clinics, we know that like 1 out of every 10 now is going to test positive. And we're seeing that. We're seeing the results in our clinics.
Exactly. So when we think about these, these metrics and these numbers, they're people. And so we also don't want things to get lost on what those are just data points. These are actual human beings. These are actually people whose lives are impacted by COVID in a myriad number of ways.
Absolutely.
It could be loss of days at work, which means loss of income, which then also could mean loss of being able to have food on the table, being able to pay bills. We're talking significant impact economically, emotionally. We've seen that and we've heard and we're learning more and more, that even folks, we have a recovery rate of 73%, somewhere between 73% right now, and has gone as high as 85%. Even with that, and when we say recovery, because they're out of the they're out of the 14-day quarantine, 10-day isolation period, and so we call that recovered. But those that have had illness or disease that's more than mild, their recovery period is longer.
Right.
Right? It's not just I'm 5 days, since my first symptoms and I'm all set. Some people, it takes a longer time for them to recover. So we want people to think about this because of, that exposure. We really need people to understand what does it mean when you're exposed, right? So that we can reduce some of this exposure.
Right.
And that's defined by us as close contact to anyone 6 feet or less for a cumulative time of 10 minutes or more, right? And so it doesn't mean that I have to just sit here with you for 10 minutes. It could be, Jane, that you and I are in a space and I'm over the time period of 10 minutes can be exposure for us. So it could be 2 minutes here, then I go do something else and I come back with you for 3 minutes.
Right.
And then as that time adds up, that cumulative period of time with you, if you've been exposed to the virus and you're carrying the virus over that period of time is what we're looking at there.
And we want to talk about that because we want people to understand. Oftentimes people get a call from their workplace. There was a case in our office and you need to know about it. Well, the person needs to step back and say, okay, was I in close contact with that individual for a cumulative amount of time for 10 minutes or more? Because it's we don't want to have blind panic either.
Correct.
And so just be measured, be calm, and just really try to figure it out. And when we think about this cumulative time, I often think about like a workplace.
Right.
You know, you might have a meeting with someone in a conference room, hopefully spaced, but even so, throughout the day.
Right.
So those are things you need to keep in mind, and really think about what you're doing and who you're around when you're not in your house.
Right. And it's not just walking past someone, right?
Exactly.
So when we're doing these disease investigations and we really want to know who contacts are, we really want to know who's exposed. It's not a person that walked past someone, right? Because that's not really an exposure.
Right.
You walked past that individual. And this exposure that we're referring to here is exposure to a positive case, because regardless of if you're wearing a mask or not, we're going to ask you, to quarantine. If you've had true exposure, right? Not just walking by, but true exposure. And that helps us also, determine what steps need to be taken for what people in that situation. And if people are exposed, Jane, you know what we want folks to do.
I'm big on staying home.
We want folks to stay at home. And while they're home, we need them to really avoid contact with people outside of their household for 10 days.
Absolutely.
That means not going to the supermarket, order in, right? Some of the supermarkets actually have delivery, so you can do that. We want folks to watch for symptoms, so continually watching for symptoms, and we can talk about what those are. And then get tested 5 to 7 days after the exposure. And the reason why we're saying 5 to 7 days, because if you go too soon, you get tested, your test may come back negative because there's a viral load, that triggers that positive test, with the test that we're using, the PCR testing. And so that's why we ask people to wait 5 to 7 days after they've had close contact. And we'll see if the person has symptoms, then we're looking at something totally different. But if there's exposure, and we're asking people to quarantine for 10 days, watching for symptoms. If there's no symptoms, after 5 to 7 days, we want them to go ahead and get tested. Now, that's not to test out of completing their quarantine period. It's that we need that 5 to 7 day period to see if the virus, if there's going to be enough virus that's produced to actually show a true positive test. We also, Jane, we've been learning and we've been hearing when we make our calls, as we hear from folks that people have been going to the emergency room to get tested. We don't want that because we really don't want to bog down the emergency room.
Right.
We need the emergency room to be used for that purpose, emergency events, not testing, right? There are options for testing at numerous sites. On our website, www.nashuanh.gov, click on COVID. We have a listing of testing sites that are not just in the Nashua region, but also around the state that we'd like for people to take advantage of. We need people to go ahead and complete their 10-day quarantine. Even if they get tested and those results are negative, we need for them to go ahead and complete that quarantine period.
And, that brings us to our next discussion, and it's a good segue.
It's a nice segue.
So, we talk about, waiting for that 5 to 7 days or, in order to make sure the viral load is built up high enough that we can detect it. And now we're entering a holiday season again. And we really need to emphasize with people, because we are entering this holiday season, that just because you go and get a COVID test and you test negative, that's not clearing you for travel. Because your exposure, if you had an exposure the day before, may not show up until 5 to 7 days later as positive. So we're really trying to discourage people using tests to provide a false sense of security, not only for yourself, but for your family.
Yes.
And so we have this next kind of visual about the holidays.
What can happen, right? So what can happen? And we know that people did do that, right? And so some of that came from, airlines wanted to see a negative test result before people traveled, or states that had the travel ban on them wanted to see a negative test result.
Right.
So that negative test result at the time that you take the test, that is your true result at that time, right? And so once you get tested, you get that result back. If there's nothing that you do in between that time that exposes you, meaning gathering in small groups, being in activities or engaged in activities or situations where there could be some at risk because you're not in your protected bubble, then that test, again, only test from that period and before, not after, right? And so you're right. We don't want people to have a false sense of security because they had a negative test 5 days ago, right? You know, and you say entering into the holiday season. To me, we're still in it. Once you get to Thanksgiving, it's just the holiday season the whole time. You go from November all the way through until after New Year's. Because right after Thanksgiving, people started to put up their
the day after.
If they celebrate, right after. The holiday season just starts right after.
Right, it just keeps on going.
Maybe it starts after Halloween. Because
it's true.
For kids, that's like a holiday, right? So, you know, we want people to do their part throughout this time period going forward.
And that involves sacrifices.
It has to.
It really does.
Right. And we know, Jane, we know people have been making sacrifices. We're asking people to work with us, to bear with us, to forbear, and continue to make those sacrifices because we still have probably a couple more months. You know, we have vaccine coming, but guess what? We're still going to have to maintain vigilance around not continuing seeing the activities that we do that allow for substantial spread.
Yeah.
So I like this graphic, and I'm going to give you credit for putting this together here for us with input from everybody saying, oh, change this. But we want people, you know, to do their part. So I think all of us at the division really appreciated this graphic that shows us exactly, you know, that testing negative today does not guarantee safe travel. It doesn't guarantee safe visiting. Even if you're not going too far away, even over to your neighbors, you know, over to a friend's house. It doesn't guarantee that unless you know that you, again, have not exposed yourself because we do know that symptoms can appear in as few as 2 days or as long as 14 days after exposure. Right. And so we want folks to be mindful of that and aware of that as well. And I like this, Jane, this holiday time frame for getting COVID. And what did you call him? I think you gave him a name.
Well, his name is Joe. But I'm open to suggestions.
Okay.
We're having some good laughs. Do we make him Rudolph or do we make him Nick? But, you know, we just chose
Carl.
We just chose like a very random name just so that the idea was that, you know, if Joe is exposed to COVID-19 and then gets tested 3 days later and is negative, that doesn't mean that there's no COVID-19 going to develop in his system because he was exposed, and it can take up to 14 days for that exposure. So
because that's the incubation period, right? And so if the virus has found its way into our bodies, it's got that time of incubation. And again, that's where that false sense of security comes in because my test came back negative. And we've, again, doing disease investigation, we've heard plenty of scenarios where a person tested negative, and then because they may have tested too early, there was not enough viral load to trigger the positive test, but they had exposure to a positive case, and then they start to show you the signs or symptoms, or they have a positive afterwards, and then they've been out in the community, or they've traveled, they visited friends, and they've done all these things now where they've been out and amongst others, and now all those folks have been exposed.
Exactly. So this graphic just tells us that, you know, he got a negative, Joe got a negative result on the 22nd, so wahoo, went off. He's going to go off and see his family and see some friends, maybe returning home, wherever home was.
Right.
And in our example, he was in contact with 22 people. And he thought he was healthy. So again, no judgment for Joe. 2 days later, Joe felt sick, and he tested positive for COVID. So now Joe's got to call all those 22 relatives and friends and let them know.
Right.
And, you know, this is why it's exponential right now.
Right. And we've actually seen this type of scenario play out. Yes,
yeah.
we've actually seen this type of scenario play out. And so we really want to, again, remind people, you know, that there is substantial community spread right now. We still want people to take personal responsibility for their safety as well as the safety of others. And I know that we say stay home if you're sick, but we also know that there's asymptomatic spread. We want people to keep their distances. We want people to wear their mask. We want people, you know, if you have symptoms, by all means, make sure that you get tested. By all means, call your healthcare provider. Some of the symptoms are so mild, but we want people to think COVID and rule that out. Wear a mask. all the time in public places, all the time in public places, in stores, in offices, in restaurants, in houses of worship, in businesses, at sporting events. Please cover it. Avoid both the large and the small indoor gatherings, especially if they're with folks that are outside of your
house,
your
yep.
normal bubble, right? Your house, your normal bubble. And then that 6 feet of distance. And I actually read something just recently this week. 6 feet is the minimal.
Right.
It's a minimal that we're asking people to maintain the distances from those that are not in their families. If you can manage a larger distance, please do, even with the mask, right? And then again, the washing of the hands, because we know the hands can be a vehicle for the virus to travel, to our eyes, our nose, and our mouths, the mucous membranes that it loves. It loves to get right in there and chomp, chomp, chomp. Let's not feed the beast. Let's not give this virus anything more than what it deserves, and that is to be stopped.
Yes.
Right? And so if we take personal responsibility, if we're very active and proactive with these things, we can see some changes. And I do have to say, I want to thank those community members that are doing this. Earlier we were talking with Mike Apollo, who is our emergency preparedness coordinator, and he said that he had ran into the supermarket for something. And he said he was so surprised to see all the people in there with their mask on. I'm like, that's great. That's absolutely great that you saw all these people with their mask on. We want to continue that.
Right.
We actually do want to continue that because we know the mask is one way in combination with all of these other things that can help mitigate, what we're seeing. Holiday travel is really not recommended. We know that folks have not seen some loved ones, and they may, take a risk and go ahead and travel as much as they can. People need to stay local and avoid travel, especially, in or on vehicles where there's multiple people, like buses and trains. And celebrate, in your home. Enjoy those little get-togethers with the people in your bubble. Do some creative things.
Yeah, and I have to say, if I could share, at first, it just felt so crazy with everyone in my house working so much and the kids remote and just so much craziness.
Yeah.
And we're a family that celebrates Hanukkah. I thought, how can I make it special? My kids were just so happy to be together.
Yes.
And light the candles.
Right.
And I said, look, there aren't really any gifts this year. At least so far. And, because I would start throwing things in the basement early. And I thought, well, I can make this special. We can just really practice the traditions. We can have latkes. We can have the donuts. We can do that together.
Yeah.
And those will be our treats.
Right.
Those are special foods. And I had my 15-year-old dancing around. As mom, do we have a dreidel? So, it's fine.
I learned the dreidel song.
Yeah.
I did. I learned the dreidel song.
But I think it's going to be special. I think we're going to really look back on this, say we all were together, and yes, we're a bubble, but we practiced our traditions, together, and I think that's okay.
And that's safe, right? That's safe for you. It's safe for your family. It's safe for your coworkers, because then when you come back to work, guess what? You did safe holiday practices, and you're not going to be putting other people at work at risk. Those virtual celebrations are also things that can be done. That was like a novelty at one point in time when they first started selling those devices, and they would show the commercials, and you'd see all, the family, on that iPad. Well, you know what? Let's make those things fun again. Let's continue to think of those things as novel and consider those virtual celebrations and making those calls. If we have to travel, if we have to do that, the mask, the social distancing while we're doing that, and washing the hands as much as possible is definitely what's going to be needed. If people travel on the plane, that's one of the safe congregate ways of traveling when there's lots of people on there. They need to make sure they keep that air vent open so that air continues to flow. I myself have been guilty of, as soon as I got on the plane in the past, switching that thing off right away because it's cold, right? That you want to keep it open. You need that airflow because you need that circulation and that ventilation.
Right.
And then when you're not on the plane and you're traveling through the terminal in the airport, keep your distance, mask on, and hand sanitizing. If you do travel outside of New Hampshire, we are going to ask people to quarantine when they come back, for 10 days. Yeah. So there's a lot of information in here. Jane, I'm glad to have had the opportunity to share Because these are matters in public health that really, really matter. These are things that can help save a life, and we're hoping that we all continue to do our due diligence, to take on our personal responsibility, to think about others, and think about that life that we could save by doing these simple measures.
Yeah, and the whole idea of back to normal is only possible if we all as a community take personal responsibility for ourselves and for each other.
Exactly.
And so on that note, we could talk about this all day.
We could talk about, we actually could, because the things in public health matter.
Yeah, but we can't because we do have our limits. But so thank you for joining me, Bobbie.
Thank you for
Be
having me.
Healthy and safe this weekend. I know that we'll probably be on the phones a lot
We're going to
this
be
weekend.
busy.
But to all of our people out there, we do still continue to have a COVID testing clinic every Tuesdays from 3 to 5 p.m. in the Elm Street parking garage. And you can call our hotline, 589-3456, to make an appointment. You can also do that online. If you're not able to do it online, it means it has filled. So again, call that hotline. It is a drive-through clinic, or you can walk in if you are unable to drive through.
Here are AARP top tips on caregiver preparedness during coronavirus. Form a team that can help with caregiving tasks. Take an inventory of essential supplies in your loved one's home. Make a list of the care recipient's medications. Schedule regular calls to fight isolation. Finally, take care of yourself too. Follow the Centers for Disease Control's guidelines for coronavirus safety. For more caregiving tips, go to aarp.org/caregiving.
Welcome back to Public Health Matters, where we talk about matters in public health. I'm joined today by a special guest, Dan O'Connell from the University of New England School of Medicine. Welcome, Dan.
Thank you very much for having me.
We really appreciate you being here, and you have been joining the Division of Public Health for the last several weeks. I believe you'll be with us for a month.
Yep.
And you're doing your public health rotation. So tell us, why does UNE have you do a public health rotation?
UNE finds it to be beneficial for our development as physicians to engage with the communities that are training us, to help see from a more granular level what types of health disparities or health issues are affecting a community and how that is translating into who we see on the hospital side. And as we go forward in our training and as we specialize more, we kind of lose sight of that. So getting this as part of our medical education is a pretty important part of what they do at UNE, and I find it to be an important part of my education.
Yeah. And I have to, speaking on behalf of the Public Health Department, we just absolutely love having the medical students join us in public health because you bring a different insight, a fresher look, and we also have you help us out a lot, so that's great too. So you're in your fourth year.
Correct.
So you didn't do most of our medical students that come are in their third year. So tell us, what you were doing your third year that you couldn't come to us and squeeze us in.
Yeah, so we have a block carved out for us in third year for community health. I was teaching I was a third year, I was teaching the second year's neurology during that period of time. So from June until end of September, I was teaching our neuroanatomy and neurology class to the class behind me, and that took up the time that I would have been in community health. So it was a requirement I needed to make up, and I decided I wanted to do it in Nashua, where I was doing the majority of my training, to kind of, as I said before, get that type of experience that you miss out on when you're, on a floor in the hospital or in the radiology department in the hospital. You don't see what happens to people before they come into the hospital, what they're dealing with on a day-to-day basis, and the lead up to someone being very ill in the hospital when you do eventually see them.
It gives you a little bit more exposure, but we always say the social determinants of health.
Yeah.
Like there are real issues that bring people, that make people ill or cause them to have poor health. Yeah. So whether that's their education or their income or, wherever they're living, it may create health issues for them. So it's really great that UNE kind of enforces this kind of public health rotation. So last year, in your third year rotation, COVID hit. Can you tell us about, were you able to finish your rotations? How did you do it?
We were able to finish our rotations. We were able to meet all the requirements that both the school and the accrediting body that oversees all medical students sets for us. But it was a bit different than I anticipated or anyone anticipated. Everyone was kind of caught off guard by this. In March, around March 15th, 16th, 17th, when cases started to really pick up, the hospital, Southern New Hampshire Hospital, decided that it was unsafe for the students to be in the hospital system at that point in time. The PPE was a little limited. The exposure risks were still being hashed out. There was a lot of unknowns. So we were asked to do our rotations virtually for the remainder of the month of March and the month of April. So I was in my OB-GYN rotation. I'd done 3.5 weeks of that, and I ended up completing that rotation virtually. So
it's hard to deliver a baby virtually,
yes, it is
very
hard to deliver a baby virtually. That is something you miss out on a lot of the day-to-day interactions with patients. We get, it's more of a kind of sterile training area where you're getting presentations and learning guidelines and stuff like that, where you're not actually getting that patient interaction. Sometimes we simulated it, but it was not the same.
Yeah, it's not quite the same.
No, and then in April I had my pediatrics rotation, and I ended up doing that entirely virtually.
Okay.
But my goal is to this spring do another pediatrics rotation, so I really get that full experience.
Great.
And I feel like I am well trained in that area.
So all your rotations in your third and fourth year are in Nashua at Southern New Hampshire?
Almost all of them. Due to the pandemic, they have recommended that we only do one rotation at a separate location. So I did a rotation at MIMED as my separate location, but the rest of my rotations have been in Nashua.
All right. And what did you do up in Maine?
Radiology. So diagnostic radiology and interventional radiology were the two rotations that I spent my time in. About 3 weeks in diagnostic radiology and 1 week in interventional radiology.
Okay. And in interest of full disclosure, this is what you hope to pursue.
That is what I hope to do. I do hope to go into radiology. I'm leaning towards interventional radiology right now, which is it's its own specialty, but it is very heavily related to diagnostic radiology, which is the aspect of radiology that most people are more familiar with.
Like the X-rays,
the X-rays,
and the CT scans.
the MRIs, where the radiologist will interpret those and provide guidance to the other providers in the hospital on how to proceed, what's going on. Interventional radiology is using those images in a live setting, in a kind of specialized surgical room to perform surgeries, minimally invasive surgeries on the spot. So using fluoroscopy is what it's called, to observe the blood vessels and spaces in the human body as we advance catheters or wires up and provide treatments such as cancer treatments. We do chemoembolizations, arterial embolizations, which stop bleeding in the spleen or the liver, which happen often after traumas, car accidents. You can also go all the way up from the thigh all the way up to the brain and treat aneurysms, treat strokes.
It's amazing.
It's
amazing how far medicine has come.
Yeah.
And do you ever do that with robots, or is there some...
IR does not really use robots at this time.
I wasn't sure. Just had to ask.
It is, so it's access to a very small point, and there's a lot of fine manipulation that goes into advancing wires the way you want them to go.
So you still need hands of a surgeon.
Still need hands still need very fine motor skills in order to do it.
Yes.
It may eventually move towards having some robotic manipulation, but that is not where things are right now.
I learned something.
Yeah.
Thank you.
Yeah.
So you're a local.
Yes.
I mean, how local?
I'm from Massachusetts.
We'll forgive you that you're from Massachusetts.
I'm from Massachusetts. I'm from Burlington, Massachusetts, which is about 35 minutes south of here, right down Route 3. And I'm currently living there. I grew up there, and I'm living there right now.
Okay.
Moved back from Portland a year and a half ago now.
And just before you went, you have an interesting past. because you're not the youngest medical student
No,
we've had.
not the youngest.
You come with a lot of experience.
Yeah.
So from what you told me, you went to BC undergrad,
Mm-hmm.
and then what did you do after that?
Yeah, so I went to BC undergrad from 2008 to 2012, and then I decided to do some research instead of going to medical school. I worked at Boston Children's. I did research on an oxygen delivery system that was injected intravenously. I also did research on sudden infant death syndrome, which was difficult, but a necessary,
Very important.
very important research to be doing. And then I ended up doing some clinical research for about 3 years on a development of a drug for helping people with substance abuse disorders, particularly opiate use disorder.
Wow. Something similar to like Suboxone or one of those.
It is
kind
very,
of
very
things?
similar to Suboxone. It's actually made by the same company as Suboxone, but which the medical name for Suboxone is buprenorphine.
Okay. Yes.
Suboxone is a combination of buprenorphine and naloxone.
Okay.
The buprenorphine's the partial opiate agonist that prevents the cravings and kind of
Right.
acts as to fill the void within the brain, the neuroreceptors that are normally craving opiate. And the naloxone is actually a misuse deterrent. It will immediately kick off any opiate off those receptors, so it kind of throws you into withdrawal. But when it's taken a certain way, that naloxone doesn't do anything; it doesn't function, and only the buprenorphine does. So this is a new
Interesting.
formulation of it that's combined with a biogel that breaks down slowly. So it's buprenorphine in this biogel, and it was injected subcutaneously, which means just right below the skin, in the abdomen, and it would last for 30 days and slowly break down. So you'd have a constant level of buprenorphine, the drug in Suboxone that is giving it its effect, in the system. So you would only need to take this injection once a month
Yeah.
instead of taking Suboxone every single day.
So do you think, I mean, so prior to coming here, you really had a lot of public health experience, whether you knew it or not,
Yeah.
because we talk about, substance misuse as one of our huge, we have a staff member dedicated to that in the division, and we have a lot of community partners that work on substance misuse and this kind of prevention. And so this is just huge to like have that background knowledge and understanding how it works and being able to speak to that to people that are trying to use these kind of medications in the community to treat their patients.
Yeah.
So that's really, and even your sudden infant death syndrome,
Yeah.
that's another thing because it can be tied to different social determinants of health
yeah,
and
correct,
a lack
yeah.
of education and how to put your infant to sleep and that kind of thing. So
Yeah, part of that was, the research on that has actually kind of slowed down because after the Back to Sleep campaign,
which was very successful.
which was that it was so successful that
Yes.
the amount of infants who are now labeled sudden infant death has decreased dramatically. So
Right.
it's not receiving the same amount of attention and same amount of funding
Right.
that it was prior. So because Back to Sleep was so successful, they're kind of winnowing down what got grouped into sudden infant death syndrome. It was kind of for a long time it was used kind of as a catch-all. Was we didn't know
Right.
what happened. It was the infant passed away sometime between being put to sleep and
Right.
waking up, and it was found out that a lot of them weren't always by the same cause, and that there are a lot of different determinants. And as Back to Sleep has taken effect, and as more and more infants, survive from infancy.
Yes, thank goodness.
I know, thank goodness.
'Cause I can't imagine anything more devastating.
Being the father of a 6-month-old myself,
Yes.
I can't.
Oh,
cannot
yes. I
imagine.
was lucky
Yeah.
enough to see a picture of the little munchkin.
Yeah.
He's really adorable.
He is adorable.
I don't know how you're functioning with a 6-month-old and
He's a-
doing all that you're doing, driving up here.
He's an excellent sleeper. It
Yeah.
really helps. He sleeps 12 hours a day.
Wow,
which
that's
is
amazing.
Amazing. But yeah, as that took effect, it kind of allowed us to get a better idea of different subsets within sudden
Right.
infant death syndrome.
What
and
were the other causes?
other causes, and kind of, so the research I was doing was more focused on the genetic, maybe the underlying genetic aspects of the people who are still dying from sudden infant death syndrome, even if every precaution is taken
Right.
correctly by the parents. So,
Oh, that's
so-
great. So now you're finishing up your 4th year.
Mm-hmm.
You're here with us. What are your impressions of, this time. We are in unprecedented times with this COVID pandemic.
That is the phrase of the day.
It is unprecedented. And you are here during a surge.
Yeah.
So you have come and assisted us at some of the clinics.
Yes. Yep.
And so to just tell us about what your role is. And
So my role with you guys is primarily as a, I am assisting in administering the COVID-19 tests, the nasal swabs, and also in, we're not really doing contact tracing anymore, but in the education and contacting of people who are testing positive for COVID-19, educating them on what precautions they should take, what additional symptoms they should watch out for, and educating people who don't have COVID-19 on what situations they should avoid, what they should be looking out for as well.
right.
And I've found that it is incredibly important work and incredibly difficult work, and it gets more difficult every day as the numbers continue to
Right.
rise.
Yeah, we're scrambling.
We're
That's
scrambling.
For sure.
Yeah, it
but we
becomes-
really appreciate every set of hands we have, and anyone that can call people and educate them, because again, that's the crux of public health is education. And so, what can we do to prevent like the next case of COVID-19?
Correct.
So your help with that is huge.
Yeah.
And it's interesting. It also gives you that patient interaction.
Yeah. Yep. Yes, it does.
So that gives you a little bit back from what you missed last year.
Yeah, and I'm sure that a lot of my colleagues weren't doing this because before COVID-19 came around, we weren't doing, the big push wasn't on, how are we going to distribute vaccine? How are we going to distribute tests? How are we going to distribute the resources? It was more, we were more able to focus on other aspects of public health, but now it just becomes so overpowering that it kind of lessens the bandwidth that we have for other things.
Right.
So it's not just COVID, the direct impacts of COVID-19. It's affecting the whole system. It's a chain reaction where if you're devoting a lot of your resources to COVID, you can't devote those resources to the other parts of healthcare that need to be addressed.
Right. And we feel that sometimes at the division where everyone's working on COVID now, and because we have to, and it's imperative. So some of our other projects that might have been up front in March or February, I should say, they've really had to be put on the back burner. And that's just the way it is. And we still have our ear to the ground, of course. Still having some of those virtual meetings, but
there's only so many hours in the day that you can work, and there's only so many people available to do the work.
Yeah.
So it becomes very difficult because that's not like that work doesn't matter as much. It still matters just as much as it did back in March. It's just this other thing has come in and is affecting such a large number of people that it would be irresponsible to not be addressing that as well.
And as public health practitioners, we often feel that when we have a pandemic, it really puts the most vulnerable in our population under a microscope or under a magnifying glass. And we really see, like, this is why we did this to begin with, is because we wanted to have good access to health and health care to the most vulnerable in our city. And so you're really seeing that hands-on when we do our COVID clinics. And, as you know, they're very popular. They're very busy. Just to give a shout out on those, we do have a COVID-19 clinic every Tuesday from 3 to 5 in the Elm Street parking garage. And you can register for an appointment online, or you can call the COVID hotline at 589-3456. And so that is available. And if you're coming next Tuesday, you might see Dan.
Yep, I'll be there.
So
all gowned up, masked up.
You might not recognize you, but you might see me too. But I tend to hide in the tent, trying to stay warm. So you're interviewing now?
Yep, I am. So in medical school, we have 4 years of medical school, and then we apply for residencies. At that point, we're licensed as physicians, but we have what we're able to do is limited, and we require supervision in order to do certain things. And residency is where we really bulk out the remainder of our training in our desired specialty. I want to do radiology, specifically interventional radiology, so I'm applying for radiology programs. Radiology residencies last 5 years.
Wow.
or 6 years if you do interventional radiology. It's just the amount of training, the amount of people you need to see before it's been agreed upon that
Right.
you have the amount of experience in order to practice safely on your own.
Right.
And of that, I need to spend 1 year, my first year, either doing medicine or surgery
Okay.
to kind of bulk up that experience, because
Mm-hmm.
so much of the next 4 years or 5 years is focused on the radiological aspects that they want to make sure that we are still
Right.
able to function as physicians in an everyday
Right.
setting.
You
and
need your
the
generalist
normal floor settings and-
rotation so that you
Correct.
understand why you're doing what you're
Yeah.
doing in radiology.
Yeah, exactly.
So, well, I know you even came from an interview today
Correct, I had an interview this
to
morning.
be here, so I appreciate you spending some time with us. And
Yep.
I think we have a couple weeks left with you, a week?
1.5, I think.
Oh, 1.5, but
Yep.
who's counting? But we do appreciate you being here with us for this rotation.
Yep.
And we appreciate anything that you're jumping in 2 feet first, and we really appreciate that. And we wish you the best of luck.
Thank you very much.
In your interviews, and you have to let us know what happens.
I will.
Because, we just love hearing about the success of our medical students.
I will. In March, I'll let you know. That's when
All
I
right.
find
Oh,
out.
March. Wow. I don't know if we can wait that long. All right. Good luck, Dan.
Thank you very much.
And thank you all for joining us for another edition of Public Health Matters. Stay safe out there. Wear your mask. Wash your hands a lot. And stay 6 feet apart from those that don't live in your house. We're in a pandemic surge, and we really need you to protect your health and your family's health. And the personal responsibility starts with each one of us. So take good care.